The TRITON3 and the PROfound trial have some methodological concerns like an inadequate control arm, for example. Both studies included patients that had already progressed to enzalutamide or apalutamide or abiraterone or new generation anti-androgens. And the control arm in these patients was that same drug. While in the TRITON3, they could receive docetaxel, but actually 61% of the patients included in the TRITON3 trial, they had already received the treatment they were given in the trial. I mean, if they had already received abiraterone, they were given enzalutamide, for example, which is the same class of drug, right? So they had already progressed to that class of drug, and the expected outcome in that scenario will be that there will be no effective treatment, that they will not respond, which is probably what happened in this study. Another problem with these trials are that they allowed for crossover, which make it very hard to interpret the results of the trials, because once the patients in the control arm progress, they are able, or they are given the choice to receive the active treatment, which will be olaparib or rucaparib. So then the data is not that clean, and it's really hard to come around and say, is this benefit because of the crossover, or even with the crossover, or the crossover just made it all worse, right? Because then you have the problem of the post-protocol treatments. So if most patients in the control arm, they receive the active treatment, I mean rucaparib or olaparib, and the patients that progressed in olaparib or rucaparib original arms, they receive docetaxel or cabazitaxel or other treatments that have been shown to be active in that prolonged overall survival, then you have to ask yourself, is the benefit seen in this trial because of the docetaxel or cabazitaxel that the patients are receiving afterwards, or is it because olaparib and rucaparib actually gives that benefit? And we just cannot know. And another problem that I see that it's also relevant is the primary outcome of these studies, which is radiographic progression-free survival. I mean, they are just measuring if the drug can shrink the tumor and keep it in a smaller volume, right? But they are not powered for a primary outcome of overall survival or quality of life, which are the main things that we care about in patients with metastatic disease. We want patients to live longer and live better. So if you ask me, does rucaparib or olaparib prolong overall survival in these patients? The question is, we don't know, and we don't know because of the crossover. We don't know because the treatment they receive is not a standard of care. It is not a standard of care anywhere to give enzalutamide after abiraterone or enzalutamide after apalutamide. That's a great question. And actually, if you check the clinical trials website, you can see when the protocol was published, and you can check if there were publications by that time that mentioned if sequencing anti-androgen drugs, like sequencing enzalutamide and then giving abiraterone, was used at that time, because it is hard to remember from many years ago, right? And there was enough evidence published that the sequencing of these drugs was not useful, and that the response of the PSA and the radiographic response was very short, that it was not even worth trying. I have lived the times of sequencing. We have sequenced patients in the past because you just don't know. And when there was abiraterone after the Latitude trial, I mean, it was reasonable to sequence these patients, but that era just lasted for a few months, and you cannot consider that it was a standard of care ever. I mean, we had already docetaxel available, so the reasonable choice would be to be docetaxel instead of sequencing by that time. it is not appropriate to cross over the patients because then you cannot conclude anything. It is too difficult to say if this benefit is due to the drug, is due to the crossover, is due to the post-protocol therapies. And if you see a very, very impressive response rate and very good results in the trial, then the industry or those that are watching over the trial can make an early stop of the trial if the results are impressive, which does not happen that often actually. But you can stop the trial and give all the patients the drug that you now know that it is beneficial. The problem is that if you don't know if the drug is actually effective, it is not good to give the subsequent drug. So when is crossover appropriate? When you know the drug is what you will give in the next patient, I mean, not in the next line, that's the correct sentence. If the patient progresses, I am going to give olaparib or rucaparib, that's what I will give. Then I allow the crossover. I will allow the treatment that is receiving the other arm because I already know that that treatment is beneficial. But until that moment, you don't know if the treatment is beneficial, and it could also be harmful. It's not that often that we see that the treatment that we are testing is harmful, but it's something that can happen, right? And if maybe you are harming some patients and then you decide unintentionally to harm the other patients, right? So if you don't have the answer, it is better not to cross over. That ship has sailed for TRITON3 and for PROfound. I think the analysis so far show that there's no overall survival benefit in this setting with this methodological design. But recently, the PROPEL trial has been published, and that's a very similar methodology, but they did not allow patients to have prior abiraterone or enzalutamide. So patients either had olaparib plus placebo or abiraterone plus olaparib. And that's a very clean design. Patients were metastatic castration-resistant prostate cancer, and they just were given one of these choices. They have not received in the past these drugs, and actually the results are quite promising. The trial was overall negative for overall survival. There is no statistical significant difference in overall survival. But when you check the subgroups, you can see that patients with BRCA1 or 2 mutation clearly separate the lines. Of course, this is just a small sample. Probably the trial is not powered to interpret subgroups, but maybe that's what we need to show that these drugs can improve survival in our patients, right? To just select patients with BRCA1 or 2 mutations and just test the drugs in these patients in a clean design. They have not received other treatments, and just give them the drugs and show that this is beneficial. And I think that's possible.